Dear students, hope you all are fine, and we are going to start with a new subject, right? That is pharmacy practice, right? So, welcome to all 7th semester B Pharm students. Your subject code is BP703TT, and under this subject, you have many topics which are related with the hospital pharmacy, current pharmacy practice, right? Drug information, lots of you can say that topics you are going to learn, which are very much important in the scenario that is right now going on. I am going to start with a topic, drug interaction, that is mentioned in your syllabus under the heading of adverse drug reaction, right? So it's adverse drug reaction, drug interaction, both have been mentioned, and so let's start with the learning objectives, right? So at the end of this series of video lectures for drug interaction, maybe it will take 3 video lectures to complete my whole topic, but then at the end of this you can say learning session, right, you will be able to infer concept of drug interaction. You will be able to understand factors contributing to the occurrence of drug interaction. You will be able to classify drug interaction, okay, and you will be able to describe in detail the mechanisms of the pharmacokinetic as well as pharmacodynamic interaction. In your syllabus, pharmacokinetic mechanisms are mentioned in detail. So we will just go through this overview of pharmacodynamic interaction, and we will go in depth of pharmacokinetic drug interaction. And definitely you will be, this is very much important, right? You will be able to identify, resolve, minimize or prevent drug interaction, right? So lots of applied part, right, that you are going to gain, right? So that point is important, that application of you can say that learning of this topic, right, you will be able to definitely go for a higher order you can say that application, right. These all you can say tasks you will be able to do, and definitely we will also go through the brief explanation of methods for detecting the drug interaction. This was previously not there in the syllabus, so this is new topic, and definitely we'll get an overview of that also, okay. So let's start with the definition. So you must have gone through somewhere, right, during your undergraduate studies, right, that drug interaction definitely is a situation where effect of one drug, right, that is altered by a prior or a concurrent administration of another drug, right. This is called as a drug-drug interaction, right. So there is a precipitant drug, there is an object drug, and definitely one of this, right, is definitely is their effect is altered. Now this alteration in effect normally is because of concurrent administration, and that is what normally we think of, but it could be a prior administration of some drug also. Say for example, if a drug is having a very long biological half life, and in that case the drug may have given one day earlier, or maybe within the same day, but maybe 5-6 hours earlier, then also it could result in a drug interaction, right. So a broad definition is mentioned here, but definitely what here I have mentioned is a drug-drug interaction, right. While actually drug interaction, we will see that drug interaction, if as such I say, then it may be drug food interaction also, drug herb interaction also. We'll see some examples in the next slide, fine. But what here the definition is given is for drug-drug interaction, okay. So definitely when an unexpected you can say that drugs are given, right, or if they are interacting, definitely it is a drug related problem, right. That is what you can assume, and that's why I said earlier that in your syllabus it is mentioned under the heading of adverse drug reaction, right. So I've gone through the review literature, and what I found is these drug interactions, they are responsible for more than 30% of unexpected adverse drug events, right. This is a huge figure, right, and this is given by WHO. So more than 30% of the adverse drug reaction, they are because the drug interact in your body, right? There is a drug interaction. So definitely there are drug related problems that you can consider. So problems definitely you can discuss in a two way. Either there is loss of effect, right? What you are referring as a object drug, right, is definitely their effect is reduced, right? So in that case definitely there is loss of therapeutic effect, right? That is what first, because of that consideration that you can make. Second thing is there is, you can say that uh, 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 unexpected increase, right? You were expecting the effect and now the effect is been higher, so you will say that sorry, that's good, effect is increased, but you know that there are some values, right, that you consider for a bioavailability, right, that your curve, right, of plasma concentration, it should follow between these two lines, right, that is minimum effective concentration, right, MEC, and maximum tolerated concentration, right, and if it crosses this line, right, then definitely toxic effects will be visible, right. So that is a, because of the dose dependent increase, you can say action, right, that definitely will increase. So the values, right, this curve should lie between this MEC and MTC, and if there is an unexpected increase, definitely it will result in toxicity, right. So that should not also be a case. So definitely we have designed that formulation, right, that it gives its pharmacological action, and if the plasma concentration is reduced, right, or maybe said at the receptor site also, if it is been, because they are not available, then there is loss of therapeutic effect. And even if there is a higher concentration or maybe at availability at receptor site, if it is increased, then also an unexpected increase in pharmacological activity and the resultant toxicity is not acceptable and is considered as drug related problem only. I hope you are very clear with this, right. So these are called as a adverse drug interaction, right. We do not want such type of interaction, but there is other side of coin also, right. Every coin has two sides. So there are some drug combinations, right, or there are some drug drug interactions which we consider as a, what we call as a beneficial drug interaction, and that also is a very good side of a drug interaction. So you may have an additive effect for which a drug may be combined, right, but that is very much understandable that 1 plus 1 gives you 2, right. So that is fine, you can understand that, right. But what is synergism, right, you must have learned this terminology also, right, synergistic activity. In medical science, when you combine two drugs and the resultant activity of both of these is higher than the, you can say, addition of this individual to effect, or what you can in layman language you can say that 1 plus 1 is equal to 11, then you can call that it is a synergistic activity, right, potentiatory activity, that is what you can say, right. So such type of drug combinations, they are called as a beneficial type of a drug interaction, right. So you can classify in this way also. These are harmful drug interactions, right, which is normally found, right, which is normally usually has been found, because this is unintended, right, you are not intended. Definitely when beneficial effects are there and once it is been known, definitely this can be used in clinical practice also. You must be knowing some of the examples, right. Let's say for example sulfamethoxazole and it's a trimethoprim, right. So it's a combination definitely that is intentionally used, so it's a drug interaction that you can consider. Similarly levodopa, carbidopa, they are intentionally combined, so that is also a drug interaction, beneficial drug interaction. Penicillin, clavulinic acid, beneficial type of an effect, right. So such combinations definitely are beneficial, and that is also mentioned very clearly in your syllabus, okay. So this is introductory part regarding the drug interaction. So let's move toward the broad concept, right, what drug interaction is. As I told you that the definition that we have seen earlier is limited for drug drug interaction, but the concept of drug interaction is also extended to some situations, right, like you can consider for drug food interaction. We'll check lots of example in this category, right. You can just see that I have shown one image where it is been balance of you can say food and drug. Most of the time it is been said, say for example when you go to physician, and what normally a layman will ask to a physician, that sir when should I take this tablet, right? આ ટેબ્લેટ ક્યારે લેવાની, સવારે લેવાની, બપોરે લેવાની, સાંજે લેવાની. And second question that you ask is whether we have to take this with food, whether we have to take this with milk, without milk, that is what. And also your pharmacist also, when you go to medical store, he also may be giving such advices, right, many a times. So what does that suggest? Definitely there has to be some interaction between that food and drug, otherwise they should have not given that advice. Most of the time physician advise that the tablet has to be taken half an hour after the food. That is because to prevent the feel of nausea, because most of the time patients, they don't like the smell, the taste of the medicines, right? They feel like vomiting, nausea feel, and that is the reason why doctors say that they have to take after half an hour after, because of that food. But ideally the tablet, the capsule that you are taking, most of the time is designed to be taken on empty stomach. Okay, we will discuss a lot on this when we will discuss pharmacokinetic drug interaction. But yes, here I would like to mention few examples. Say for example, grapefruit juice is a very good example, right? Remember, grapes are different, and grapefruit juice is a grapefruit is different, right? Grapefruit is a citrus fruit, right, which is definitely involved in many important drug interactions. Similarly, you must have you must be knowing one very important drug interaction of, because that your antidepressant drug, that is MAO inhibitors, and that is classically referred as a cheese reaction, right? So this cheese, that is tyramine rich food, they do interact with some drugs like MAO inhibitors, and in that case they may produce a severe or serious type of an drug interaction, right? So drug food interaction also is a type of a drug interaction only. Similarly, herbs, which are normally considered as a very innocent products, right, they are not supposed to produce any adverse effect, right? But then definitely when we are claiming any chemical constituent for their pharmacological action, then definitely the interaction is possible with the allopathy also, right? So herbs also, they do have phytoconstituents, and in that case when you take with allopathy medication, it is possible that it may produce, and because that drug interaction, right? Say for example, St. John's wort, right? This is a very famous drug, right, and that is having a widespread application in many of the CNS disorders. And this herb is rich in amines, right? I have just shown here an image of St. John's wort. This is rich in amines, and in such case definitely it will interact with many drugs which are acting or which are used in treatment of CNS disorders, right? So St. John wort is an example. Some of the laxatives also you can take as an example, right? So say for example, a patient is taking Kayam Churna, right? Regularly he is using, right? Kayam Churna is actually trednem. We should not be using trednem. But then you consider Senna, right? Senna is laxative. So that Senna the patient may be taking, and he may not be aware that maybe antihypertensive medication or maybe anti-diabetic medication he is regularly taking, the bioavailability of this drug is affected by the presence of Senna. So such herb products definitely also you need to consider as a part of drug interaction, right? See, once you start thinking in this way, right, definitely topic becomes interesting. You just go for practical examples, right, and that practical examples will give you more, because that understanding, right, of the topic that you are learning. Fine. Moving toward the third is environmental chemicals, right? So this is definitely very well reported. Smoking is a hepatic microsomal enzyme inducer, right? So it induces cytochrome P450 enzyme, and in that case definitely once more enzymes are there, the metabolism of the drugs, right, which is definitely by those enzymes, will be on the higher side, and their bioavailability will be less. So environmental chemicals also do have a drug interaction, right? Just a few years ago I have gone through a research article where they have mentioned effect of charcoal. Now normally charcoal is not taken as such as an environmental chemical or maybe as an food, but most of us are vegetarian, so definitely. But then say for example, if person is eating non-vegetarian and then they are going for maybe a barbecue of that, and such a case definitely there will be presence of charcoal, right, because of the smoke, right? If burnt part of that meat, or maybe in case of vegetarian barbecue also, there may be some presence of charcoal, right? And that charcoal also is, because it is, you can say that it could have a very good effect on the, you can say, adsorption, right? It is a use also for that purpose. Activated charcoal is used also, right, in treatment of, you can say, that poisoning for that purpose. So presence of this charcoal in a food also can lead to reduction in the absorption of a drug, and it could lead to a drug interaction, right? So very lively example that we have taken, right, in case of this environmental chemical. Moving toward the next is drug laboratory test interaction, and you will be surprised to know that laboratory can be either false positive or false negative because of presence of many drugs, right? Some of the examples I have shown here. You may also try to find some more example. If you just simply Google it, right, then definitely you will come to know many examples, right, which can modify the interpretation of the laboratory test. Remember that laboratory test interpretation also is a part of your syllabus, and maybe somewhere I also will take a video lecture, right, and will upload for you definitely. Okay, yes. Coming back to the current topic, drug laboratory test interaction. Say for example, cephalosporin. Now normally a diabetic patient, right, go for either blood test or urinary glucose test, right? So blood glucose definitely is more suitable, and recently definitely HbA1c is more widely used. It's a gold standard for diagnosis of diabetes. But still in many areas, many parts of country, it is urinary glucose which is measured, right? And normal urine analysis, biochemistry practical also you have done this, right? Estimation or identification of glucose in urine, right? You know that glucose is not a part, normally a part of a urinary constituent, so it's an abnormal constituent. And if it is found, right, glucose is found to be present in urine of a patient, what you consider that the patient is diabetic, right? That is what we consider. But here, if a patient is on cephalosporin, then also such false positive result, and what you will interpret that patient is diabetic, while actually he is not, right? The urine is showing the presence of glucose because patient has taken cephalosporin. Similar observation can be made for serum creatinine also. Spurious level of creatinine can be observed in those patients where cephalosporin is administered. In such a case, creatinine is considered as a part of, you can say that, renal function, right? The presence of normal level of creatinine, right, is definitely is considered as a very important biochemical parameter for the normal functioning of kidney. And if this serum, because the creatinine is found higher, and what you will feel, right, what the laboratory technician will interpret is that a patient may be having a kidney related problem, renal failure is the case, right? Similar sort of, you can say, example I have shown for the proton pump inhibitors. You know that these are antacids, right, which inhibits K plus H plus ATPase pump, right? Now normally earlier it was a scenario that no acid, no peptic ulcer, but now you know that the pathology of the peptic ulcer, it is very clear that no H. pylori, no ulcer, right? Peptic ulcer, H. pylori is always a case. And this H. pylori, you will be surprised to know, right? I am trying to draw, right? It's not that easy to draw in this, but then consider that this is a you can say that H. pylori which has reached to your stomach, right? Your stomach mucosal lining is having a high quantity thick mucus, right? And definitely now this H. pylori, once it has entered inside your body, now it will be exposed to a very low pH because of the secretion of HCl, right? Gastric juice contain HCl. And the problem with this H. pylori bacteria, that is Helicobacter pylori bacteria, it cannot survive in acidic pH. Okay. So for that purpose, what this H. pylori bacteria do is, it will try to release some enzyme, right? Which enzyme? So the enzyme that are released by, you can say that this H. pylori is urease enzyme, right? What is the name of enzyme? It is urease, and you know that ASE refers to breakdown, right? So ASE refers to breakdown, and here is a breakdown of urea. So this urease enzyme, once been released in surrounding of this bacteria, definitely it's a flagellated bacteria, so it can also move in this thick mucosal layer. That is how also it can survive. But main is release of this enzyme in the surrounding medium. So once urease is released, urea will be broken down into ammonia, and if ammonia is there in the surrounding, it will be able to still be survive in this acidic pH of the stomach. It will produce infection in this region pylorus, and that is how it is been named as H. pylori, right, Helicobacter pylori, because it is affecting the pylorus. So that normally this urea, right, urease enzyme, it is the very important way to diagnose the presence of H. pylori. Whether the patient is having H. pylori bacteria or not, that can be detected by giving a radioactive carbon meal, right, that is urea, to a patient. Once you give a radioactive urea, and then if urease enzyme is present, definitely levels of CO2, radioactive CO2, can be detected, and that is what is called as a urea breath test. But if you give proton pump inhibitors, then this urea breath test, it will give a false positive result, right. So see, the detection, right, definitely physician, the skills of physicians are very important, but biochemical estimation, right, this type of supports, right, from the laboratory data are very important for management of any patient. And if your drug is modifying laboratory test, the implications are quite high, right. So drug laboratory interactions also is a part of drug interaction. Okay, last one is the drug disease interaction. Yeah, you can take all examples here which you consider as a contraindicated drug, right, in so and so disease. Say for example, beta blocker are contraindicated in asthma, rightly so, because in asthma you want bronchodilation, right, and that's why you give salbutamol, terbutaline, those are beta 2 receptor agonist, right. But if you give beta blocker, definitely it will result in bronchoconstriction, and if they produces bronchoconstriction, definitely they will worsen the asthma. So this is a drug disease interaction, right, or what we say that in simple word is beta blocker is contraindicated in asthma. It should not be used in asthmatic patient. Other antihypertensive drug should be used in asthmatic patient, right? Likewise, similarly, aspirin by direct effect as well as indirect effect through the COX inhibition, by reducing the prostaglandin synthesis, it decreases the mucus thickness, and that is how you should not give aspirin to the patient, right, in which peptic ulcer is there. Otherwise, it will increase the chances of GI bleeding, right. So these are some of the examples of drug contraindication, but other examples also you can consider where contraindication is not there, but still the effect of drug is modified. Say for example, anemia. Now normally if you give an iron containing preparation, iron salts, right, as such, say for example, many salts are there which are having problem of solubility, and nowadays you normally recommend patient soluble types of iron salts, but still also the absorption of iron is erratic and is low, is not that high, right. So if iron containing preparations are given to normal person, the absorption is low, but if same preparation is given to a patient of anemia, then what you will see is an increased absorption of iron. So here presence of disease has modified the effect of drug, and that's why it is considered as drug disease interaction, right. I hope now you are having a very broad concept of what is drug interaction, right. It is not only limited to drug interaction, it is also drug food interaction, drug herb interaction, environmental chemicals, laboratory test, disease, all things we consider as a part of a drug interaction. Fine. So now let's check the second learning outcome, right, third learning outcome that we have mentioned in our earlier slide. So factors contributing to the occurrence of drug interaction, and first one is multiple pharmacological effects. Now you are in 7th semester and you have clear pharmacology of 4th sem, 5th sem, 6th sem, right, and you must have observed, right, in textbook also, reference book also, and maybe in exam also, that wherever pharmacology of so and so drug is been asked, say for example, examiner like me, right, normally I will not ask, but then definitely I will ask, write a note on ACH, write a note on adrenaline, right, write pharmacology of adrenaline. So what you will write is effect on CVS, effect on CNS, effect on GI tract, effect on respiratory tract, all system one by one. પછી effect આવડતી ના આવડતી હોય ગપ્પુ મારી એ વસ્તુ અલગ છે, right, that definitely is the other part, but you will mention that headings very clearly. And what does that explain? That this drug, right, is having action on CVS also, CNS also, digestive system also, respiratory system also. So most of the time a drug is having a multiple pharmacological action, right? And that is one of the drawback, right? Definitely you cannot correct that part, but very much important drug interactions you can derive from this multiple pharmacological action. So let me give you an example, very good example. This is a drug. You must be recalling your pharmacology, that which category it belongs to or for what purpose it is used. Yes, you are right that it is antipsychotic drug, chlorpromazine, right? It's a phenothiazine, right? And that is used in treatment of, you can say that, schizophrenia, psychosis. Second one, yes, push your brain, right? થોડી કસરત કરો. આ લોકડાઉનમાં થોડુંક બ્રેઇન જે છે ને એમાં પેલું ધૂળ ચડી ગઈ છે, કાટ લાગી ગયો છે, થોડીક મહેનત કરવી પડશે. એમિટ્રિપ્ટિલિન, વેરી ગુડ. ઇટ્સ એન એન્ટી ડિપ્રેસન્ટ ડ્રગ, a tricyclic antidepressant drug. And third one, that is trihexyphenidyl. હા, આમાં થોડુંક વધારે તકલીફ પડશે, right? This is an anticholinergic drug which is used as an anti-Parkinsonian agent. Okay, you can use both type of drugs, dopaminergic agent also and anticholinergic drug also in treatment of Parkinson. So this is used in treatment of Parkinson. Okay, now if you just go through the primary effects of all these drugs, this is antipsychotic, this is antidepressant, this is anti-Parkinsonian. But there could be some situation where you have to use all these three drugs in a patient, in a single patient. Now it does not look like that they are having any sort of a drug interaction. At first look, it does not look like that. But when you go through a comparison, then you will come to know each of these is having a mild anticholinergic activity, right? Antipsychotic drugs, phenothiazines, they are somewhere, they are mentioned as a large actyl. Large actyl means they act on every receptors. They act on dopaminergic receptor, 5-HT receptors, adrenergic receptors, muscarinic receptors. So anticholinergic activity is there. Our importance is anticholinergic. Amitriptyline, yes, also it does have anticholinergic activity, and this is definitely an anticholinergic drug itself. Individually when you give this drug, then this anticholinergic activity is very minor, right? You just consider like this is one, and second one also is producing one, third one. But when you give this in combination, it is an additive anticholinergic action that you will observe. And what you will observe, resultant effect is, right, overall what will be, even if it is an additive action, then what will it will produce is a severe anticholinergic action, dryness of mouth, cycloplegia, right, urinary retention. These are all adverse effect as an anticholinergic activity you will find when you give these drugs in combination, right? That's the beauty of pharmacology, and that's the beauty of pharmacy practice also, right? That you have to apply the knowledge which you have learned until now, right? And that's why it has been kept after 6M, right? As once you have learned all concepts of pharmacology, then it has been kept, right? So go for a thorough knowledge of pharmacology, then definitely you will be able to narrate such examples, right? This is one example, you can take many examples. Moving toward the second point, that is a factor contributing to the occurrence, that is multiple prescribers. Now this also is a very common scenario nowadays. We all have family physician, right? Definitely that family physician is always, whenever we have a small sort of a complication, we normally rush to him or her. But then now the scenario is we have a specialist or super specialist, right? So definitely wherever needed, we also do visit the super specialist, and in that case sometimes we hide information that we are also taking such and such medication prescribed by our family physician. Or it is also a possible case that even if you mention, then also sometime the problem is because of common prescription. Say for example, physician, right, that is because of fever has prescribed you paracetamol, right? So that is rightly so, paracetamol can be used as an antipyretic, that is very good. Similarly, you are also having toothache, right? So you are visiting a dentist, right? દાંતમાં કંઈક ને કંઈક દુખે છે, તમને પેઇન થાય છે. So for that purpose you are visiting dentist, and then dentist also will recommend you a PCM, right? Because normally for a toothache, right, ibuprofen or a paracetamol is used, right? It's a drug of choice. So in this case both physicians have given you paracetamol, and any of that is not aware that you are also taking paracetamol from other physician, right? You are also having one more prescription. So definitely multiple prescribers will lead to such type of a situation, right? And in that case definitely drug related problems, drug interactions could result. right? You can also consider some other examples. Say for example, patient, right, is taking some medication like antihistaminic, right? This is a very common season, right, where you will find such type of a problem, like say for example sore throat, or maybe allergic rhinitis, common cold, and in all that case antihistaminics are given, right, in cough syrup or maybe in tablets used for the treatment of cold. So antihistaminics do lead to, because that sleepiness, right? They have, right, and that's why if you just go through your basics, you classify antihistaminics in two categories: sedative and non-sedative antihistaminics. Even non-sedative antihistaminics do have potential to induce sleep. I don't know why they have erased them, but then still they do have potential to produce the sleep, right? So in that case, say for example, you've been given a drug like antihistaminics, and maybe some other physician has given you an anti-anxiety drug, anxiolytic drug, right, for treatment of anxiety. Now definitely if you give this two drug in combination, the depression effects will be visible, right? Consequences will result in excessive depression effect, right? So that's a multiple prescription. In such a case, definitely you should be very frank to your physician, your super specialist, that sir, these are the list of medication that I'm taking, right? And in that case, definitely possibility of reducing such interaction could be there. Okay, moving toward the third factor is use of non-prescription products, what you call as a OTC, right, over the counter drug. And this is a big issue, right? Even in developed countries, this is a big issue, right? Because OTC medication, you never come to know, right, patient is taking some OTC medication, and normally patient also do hesitate to tell that I am taking such and such medication, right? Maybe herbal medication if they are taking, maybe some medications like NSAIDs, right, non-steroidal anti-inflammatory drugs. These are some frequent drugs which are taken as an OTC, right, non-prescription products, and patient will never tell physician, or physician also when asking about the history of the patient will not come to know about this OTC medication, right? Such a case, definitely chances of drug interactions are very high, right? This is one of the big reason for drug interaction in developing as well as developed countries. Patient non-compliance, right? This is again a very, you can say, a common factor, right, that could contribute to the occurrence of drug interaction. You can just see that, right? Here I have mentioned here that doctor is advising that you should just give up smoking, you should not drink alcohol, and you should not take oily food, right? So that is the best thing, that is the first option, and then just immediately patient asks that what is the second best option, right? So such scenarios are observed with many patients, and they do not comply, right, in terms of, you can say that the non-therapeutic approaches that are recommended by the doctors, or maybe timing of the medication. Say for example, two medications are taken, right, in a single day, and physician know that definitely there is a chance of drug interaction, and for that purpose what he will do is he will give a gap of 5 to 6 hours, that this tablet has to be taken in morning and the second tablet has to be taken in the evening. And by chance if the patient has missed the dose in the morning for the tablet 1, what he will do is he will take 2 tablets at the time of evening, and then definitely drug interaction. Sometimes it also happens that same drug, the patient, because he has skipped the earlier dose, he will take double dose of medication, because he might have skipped the dose, and to contribute to the effect, right, what he just like you said self medication, right, what he will do is he will take that medication in a double dose. So that sort of, sometimes also it happens like that, patient feels that this single tablet is not giving proper effect, it is still a very less effect, sub-therapeutic effect, and that also cough syrup, right, it happens normally that this 5 ml syrup, what it will do, let me take 10 ml of this syrup, then I will get good effect. So such type of a non-compliance could also lead to a drug interaction and adverse event, right? So that's a big, you can say, a factor that you can consider. And finally, drug abuse. You know that some of the individuals, they have a tendency to go for an, you can say, misuse of the drug, deliberately abusing, you can say, such type of an, you can say, drug, right? In that case, definitely, like amphetamine you can consider, or maybe opioid analgesics, anxiolytics, or in some cases even some of the antihistaminics. These are all, you can say, abused, right? And such drugs, definitely they will never tell to the physician, and it will never come to the patient history. And once it is not there in history, and there is a high chance that these drugs, as such, these are potentially detrimental drugs, right? These may harm your health, and if you are using those drugs in combination with the drugs that are given in prescription, definitely it will be a very big issue, right? So with this we have completed major factors that could lead to occurrence of the adverse. So now moving toward the risk factors of the drug interaction, right? So risk factors for drug interaction you can divide in two categories. One, patient related factors, and second is drug related factor. Patient related factors, many factors we are going to discuss. First one is age, right? Definitely all formulations again are designed for adults, normal human population, right? So we are not considering the special population like pediatric, geriatric, and you can say that pregnant woman, right? That we are not considering, right? Pregnancy we are not considering because we are discussing the point of age. So pediatric case, definitely formulations are available, and nowadays people are well aware, right? Because we are visiting pediatrician, and definitely the pediatrician will give formulations which are prepared specially for children, right? Or maybe that could be a separate topic of discussion, right? That wherever we'll free, we'll discuss pediatric pharmacology. But for pediatric it's not big problem because separate formulations are available. But for geriatric it is a big issue. You don't have a separate formulations for geriatric, and in that case as such, because of the aging, and second thing is because of the so many comorbid conditions, so many diseases, right, present in the old age, hypertension, diabetes, cardiac disorders, these all lead to multiple, you can say that prescription, and such a case your kidney function, liver function, these are declining, your all organs, right, their functions are declining. So age could be a very important factor, and chances of drug interaction in geriatric population, right, aged population is very high, right. So age is a very important consideration. Second is a genetic factor. Genetics also do have a very important role, right? And if you just recall your previous semester, I have explained you the details of isoniazid, right? Metabolism of isoniazid is governed by genetics, right? And that is through N-acetylation mechanism. If you have time, you could also check my video lecture, right, for because that drugs acting on the anti-tuberculosis, where I have discussed the pharmacology of isoniazid, right. Now for this isoniazid there are two types of population, actually three types of population. One which are slow acetylators, we called as a slow acetylator. Second which we called as a fast acetylators, right. And third is also possible, right, which you can definitely Google it, that is intermediate type of a population, right. So metabolism here is fast, here is a slow, right, and here is intermediate, right. That is because here the genes, both genes are recessive, right, they are not expressing properly the enzyme responsible for the metabolism. Here both genes are dominant, so they are fully expressing the enzyme, and that's why that metabolism is normal. Here there is a heterozygous condition, that is one gene is recessive, second is you can say that dominant, and there is a co-dominance, right, and because of that intermediate sort of metabolism is also possible. Now the problem in slow acetylator is you have lots of, because that biological half-life of the isoniazid will be higher. In such a case adverse effect like peripheral neuropathy, hepatotoxicity, also these also chances are higher. So you need to adjust the dose accordingly, you need to monitor the adverse effect also, right. Say or say for example, if this type of a drug like isoniazid is given with phenytoin, right, in that case the drug interaction in case of slow acetylator is definitely because higher as compared to fast acetylators. The effects in case of slow acetylators because of this drug interaction are severe. You know that phenytoin toxicity, right. Here the problem is because of the hepatic metabolism, and such a case definitely if isoniazid slow acetylator patient, if they are given phenytoin, the metabolism of phenytoin will be low. Such a case nystagmus, ataxia, these all adverse effect of phenytoin will be higher, and this type of an effects of combination are more observed in case of slow acetylator. So that is how you can consider that genetic factors will come into the action, right. So age, genetic factors, both are very important factor. Moving toward the third is a disease state. Definitely when you have disease in your body, the pathology is different, right, and that case definitely because that if normal physiology is there, definitely the all pharmacokinetic parameters they are working normally. If pathology is there, then definitely the all because kinetics of the drug will be altered, and that's why chances of drug interaction is higher, right? Say for example, if there is a kidney disorder, right, so the biological half-life of drug will be higher, it will not be get excreted out easily, and the two drug which were previously not interacting now may have an interaction, right? Similar case you can consider for renal function, we have just discussed, hepatic function, right, because metabolism is governed by your liver, right, majority of the drugs get metabolized by liver. So this definitely will get if they are impaired, right, renal impairment is there, hepatic impairment is there, it poses a risk factor for you can say initiation or maybe occurrence of a drug interaction. Diet definitely do have effect, right? GI motility, the stay of the drug in GI tract, overall absorption, right? This all we get, pH of your GI tract, right? These all have effect on you can say that your absorption of a drug, bioavailability of a drug. So presence or absence of a diet definitely can also be, right? Say for example, if a person is eating lots of acidic food, right, so in that case definitely drug which was there in the previously in a, you could say that maybe a non-ionized state now will be in ionized state, and in that case there may be a chance that it could produce a drug interaction, right? So this diet definitely is also to be considered. Alcohol consumption in any case definitely, because alcohol itself is a drug, right, is itself is a drug. So in that case initially you know that it inhibits the enzyme, but then eventually it leads to hepatic macrosomal enzyme induction, and then finally definitely also other effects, right, effects of alcohol on liver, effects of alcohol on brain, these also you need to consider, and definitely alcoholics do have very high chances of drug interaction. Okay, finally it is the smoking, again we have discussed that it is a hepatic macrosomal enzyme inducer, and in that case it will lead to, right, patient may not be aware of also, right, that smoking is changing its bioavailability of the drug that patient is taking, but then definitely it is a considered risk factor, right. So these all are patient related factors, right, that you can discuss as a risk factor for drug interaction. Now moving towards the drug related factors, right. So there are definitely every drug is having a chance of drug interaction, you cannot rule out any drug, but there are few drugs which you will frequently you can say, encounter in drug interactions, right. So those type of a drug include the drugs which are having a narrow therapeutic index, right. Say for example, just I have shown in previous slide, right, that the what we are interested is in the therapeutic index of a drug, and the level of the drug is should be there between the MEC and MTC. If it crosses MTC, then also it's a problem. If it is, this chart is below MEC, then also it's a subtherapeutic dose, it is not having any sort of an effect, right. So this curve should be maintained, that is what we have learned, and then in that case definitely if this range between MEC and MTC is broad, then there is no issue. But consider for a drug this level of MTC, right. So for example, I am drawing for another drug, right, drug B, where the MEC values, right, this is MEC and this is MTC, minimum effective concentration. So here you can see that the range is quite low, right, therapeutic index is low. If you just slightly increase the concentration, it will cross this MTC value and it will result in toxicity. If the dose is slightly been reduced, then it will come below this MEC and then there is a loss of therapeutic action. While say this you can just learn with an example, say for example paracetamol. Now paracetamol normally is given in a dose of 500 milligram, but even if you go for a 625 milligram, it will not produce that toxicity, right. The toxicities are not that severe, or, and it is been mentioned in the books that it can be given in doses up to 1.5 gram or 2 gram also very safely, right. It can be given, but then normally we give it 500, that's another case. But then here you can consider that even if 500, 10%, 20% deviation of the dose, it is not resulting in toxicity. While in case if you give for drugs like lithium, right, if you go for a drug like digoxin, right, these you must have seen in the drugs acting on cardiovascular system in case of congestive cardiac failure, right. So very narrow therapeutic index, if you give a slight increase in the dose, it results in toxicity, right. And such type of drugs, they are frequently encountered, right, in the list of drug interaction, right. Warfarin, all anti-epileptic drugs also, warfarin, carbamazepine, right, Here also I would like to mention that this drug warfarin, it follows a mixed order kinetic, right. Initially it is sorry, not for warfarin, it is for phenytoin, right. I just wrongly mentioned, not for warfarin. Like say for example drug like phenytoin is there, right. You know that phenytoin is anti-epileptic drug. So initially phenytoin follows first order kinetics when it comes to metabolism, but at higher doses phenytoin, the enzyme becomes saturable, and the doses, consequent doses if you are giving, right, if say for example person is having acute toxicity, the metabolism of phenytoin does not follow first order, it follows a zero order kinetic, right. So that means it is independent of concentration, independent of metabolism. And such type of an example of a drug, phenytoin is a case, aspirin is a case, alcohol is a case, where you find mixed order or maybe a zero order kinetic. In such a case, the chances of drug interaction, adverse event are very high, okay, because exponential increase in the plasma concentration can be found. There are some examples which are well recognized either as enzyme inducers and enzyme inhibitors. They are also frequently encountered in drug-drug interaction. Say for example, patient is of HIV, right? HIV, that is human immunodeficiency virus, that is it leads to AIDS, and you know that in case of AIDS it leads to compromise in the immune system, right? So immunity becomes weak, and most of the time it happens that patients of AIDS, they have all type of an atypical bacterial fungal infection, and nowadays it is a very common scenario that patients of AIDS, they also have tuberculosis. This is very common scenario. So you give, because that anti HIV medication, that is protease inhibitor, right. You know that protease inhibitors are very well they are very important part of heart, that is highly effective antiretroviral therapy. And for treatment of tuberculosis you also need to give rifampicin, and there you have such type of an interaction, right. So because this rifampicin is a hepatic microsomal enzyme inducer, right, so such a case definitely it will increase the metabolism of anti retroviral drugs, right, and then effectiveness of antiretroviral drug could be decreased. Okay, so very important, clinical important examples that you can consider in this case, right. So those examples should be known to a pharmacist, right. As a pharmacist, as a hospital pharmacist, as a clinical pharmacist, you should be aware of such examples. And third examples are drugs which are having low bioavailability, right, because here also the bioavailability is very low, as such it is low, and if you give a drug which reduces further absorption, further leads to a reduction in bioavailability, right. Maybe say for example drug if again I will take an example of paracetamol, right. If your dose is 500 milligram, and if there is an 5% reduction in the bioavailability, it will not make much difference to paracetamol. But consider that your drug is having a dose of 5 milligram, right. Here 10% reduction will lead to 450 milligram. Here 10% reduction, even if it looks like a very small, but then the effects are quite great, right. Just a simple reduction, right, it is a 10% reduction, right. Here a reduction of a single milligram will not make a more difference, right. That's what I'm trying to say. 499 from 500 does not make much difference, but when you reduce your 5 to 4, right, so this is a 10% actually. So such a effect that could be observed, right, where drugs are having a low bioavailability profile. So this is all about the risk factors, right, for the drug interaction, right. So now moving towards the mechanism of drug interaction, and this is last topic of today's discussion, and then I will give you an assignment. Okay, so mechanism of drug interaction, you can definitely classify the drug interaction on the basis of these two mechanisms. Very simple, right. You know the definition of pharmacokinetics. What do you mean by kinetics? Movement of what? Pharmacon, that is drug, right. And kinetics, you know that it is ADME, right, that is absorption, distribution, metabolism and excretion, right. So it is pharmacokinetics refers to, it is the ADME of a drug, right. So absorption, distribution, metabolism and excretion of a drug, if it is altered by presence of another drug, it is very simple that it is considered as a pharmacokinetic drug interaction, right. So here precipitant drug is altering the kinetics, that is ADME of the second agent, right. that is the object drug. And definitely when you change any of this, either absorption or a distribution, you can correlate that it will almost lead to change in a plasma concentration, which is a very characteristic event here. If it is a pharmacokinetic drug interaction, resultant change in plasma concentration is always observed, right? This will be always a scenario in case of pharmacokinetic drug interaction, right? So two drugs we are discussing, one is a precipitant drug, second is an object drug, right? So the effects are altered of object drug. By whom? By this precipitant drug. Okay, that is what you mean by pharmacokinetic drug interaction. Pharmacodynamic also, you know that it is a receptor level change. So definitely here we are considering in the actions of the, you can say, drug, right? So those situation, right, in which drugs are either having similar pharmacological action, right, then it could be resulting in either additive sort of an action or maybe potentiatory action, or if it is having opposing sort of action, antagonizing the pharmacological actions. If they are administered concurrently or maybe in priorly, right, that also is possible, then it could result, right, in a situation, right, in which sensitivity or a responsiveness of a tissue to one drug is altered. In short, pharmacodynamics of the object drug are altered by precipitant drug. Then you will refer it as a pharmacodynamic drug interaction. Okay, so definitely pharmacokinetic interactions look more dramatic, right? This situation, it looks more dramatic when you will learn few examples, but clinical scenario pharmacodynamics are equally important, right? So both of this, right, pharmacokinetic as well as pharmacodynamic, we are going to discuss in detail in next lecture. Second lecture will be dedicated for the example of pharmacokinetic drug interactions only. Okay, and yes, here it is possible that plasma concentration may not get changed. It may get changed also sometime, but it is not always possible to have a such type of a scenario that plasma concentration. So it is normally without resultant change in the plasma concentration. That is what you can say. Okay, while in case of the pharmacokinetic drug interaction, yes, it will result in the always, it will always result lead to a change in a plasma concentration. Okay, so with this I complete today's lecture, and yes, it will be always a case that I will give you few comments or maybe few sort of a simple questions, right, as an assignment, right, because in online teaching your contribution is equally important in any case of teaching, right? Definitely your contribution is more important as far as in any scenario, right? So because it is an online way, we are not having a bi-directional type of an communication. Just I request you go through review literature. I am using the book Remington and Parthasarthi, right? These are two books which are I am using, right? Definitely you can use any book, but this is just for your reference. And as a part of your assignment, this is what you need to submit. This is very simple. Even you can Google it and you can find out 5 examples of this, and you can find out enlist, you can say 3 examples of drugs having poor bioavailability, narrow therapeutic index, drugs having zero order, mixed order kinetics, right? And also try to find out 5 examples of beneficial adverse drug interaction and drug interaction, right? This many of examples you will be able to write just on the basis of listening my lecture, but still for finding few more clinically important example, or maybe say for example I have mentioned 2 example, you need to find 5 example. That is what your exercise is. Okay, I hope it is easy and it could be easily done. Okay, and I expect the same, right? Wherever I will take presence, wherever if it is a case that internal evaluation is based on your assignment, these all things will come into action, right? These all will be considered as a part of your evaluation, right? So with this we complete our lecture, and next lecture we will discuss pharmacokinetic drug interaction. Thank you very much.